The contents for today will talk about the evolution of cements for indirect restorations for luting to bonding, resin cements factors affecting clinical performance, classification of resin cements, and clinical procedures.
Do you have to share the slides?
Share the slides. Yeah, sorry, I forgot. Yeah. Is it clear now?
Yeah, perfect.
Okay. So, indirect restorations such as crowns, bridges, inlays, onlays, posts, all the cements plays a vital link between the restorations and the tooth. Although the retention of the crown, bridge, and inlays, onlays depends primarily on the friction between the walls of the preparation and the internal surface of the restorations. Luting cements include zinc phosphate cement, polycarboxylate cement, glass ionomers. All of this is conventional cements that we used before. But over the years, direct restorations involved newest materials. Okay, what's the basic requirements of the luting agents and how I can choose the best luting agents for cementation? We should focus on these properties related to working time, adhere well to both tooth structure and cast alloy, provide good seal, non-toxic to the bulb, and have adequate strength, properties, and be compressive into thin layers, have low viscosity and low solubility, have good working and sink characteristics. The evolution of cements for indirect restorations from luting to bonding. Luting cements, like zinc phosphate cements, the oldest of the luting cements that has been used over 100 years. Zinc phosphate cements have been used successfully for metal supported restorations with very good mechanical retention. And these cements, however, are not recommended for use in ceramic crowns and composite crowns because of their inferior compressive and flexure strength. The disadvantage of zinc phosphate cements is dissoluble in oil fluids. They discolor and have the weak physical and mechanical properties, and it's very limited. What about the polycarboxylate cements? Polycarboxylate cements, it's too viscous. And the main application of polycarboxylate cements today is for cementation of the long-term provisional restorations. Glass ionomer cements. I like to use it for metal PFM, for zirconium sometimes. These cements have two main advantages. First, it offers some degree of chemical adhesion and it releases fluorides. For the resin modified cements, when we have weaker restoration, we use resin cements. Okay, but now for resin modified glass ionomer to improve the weaker necessary than conventional glass ionomers. Bonding cements, the resin cements, it has high bond strength and it provides more retention than conventional luting cements because of their hard bond strength to the tooth structure. And the resin cements provide more retention than conventional luting agents. Okay, how we can choose the right cement, luting or bonding? The decision depending on two factors. The restoration materials, the most critical factors in the choice of the cement is the strength of the restoration material, okay? So, the weaker the material, the stronger should be the cement. Understood? The weaker the material, the stronger should be the cement. But alumina, zirconia, ceramics have high strength value and do not necessarily need bonding cements, okay? And second factor is the amount of retention needed. Preparation form, taper length of crown walls, preparation with taper less than 12 degrees and with adequate height, 4 mm at least, are considered retentive and not need to be bonded. The more is the need for bonded cements is the more preparation become non-retentive. And this is the tree. It can help us to make a decision of the cement choices. Now let's talk about resin cements, factors affecting clinical performance. The resin cements are the newest type of cementation for indirect restorations, and they have the ability bond to tooth structure and internal surface of the restoration. Resin cements are composed of the same basic components of the composite restorations, but with lower concentration of filler particles. These cements have higher compressive flexure and tensile strength than conventional cements and can be used for almost any types of restoration and restorations materials. These cements, however, are more complex than in conventional cements for sure and are highly technique sensitive. The most important factor for affecting the success of resin cements is the bond strength. Understanding all how of these factors are related will minimize the errors and enhance the longevity of the bond in direct restorations. So, we have to understand the effect of polymerization on the cement film thickness, opacity, and translucency of both the cement and restoration shade of the restorations too. Factors that influence cement selection. The correct cements depend on cement properties, clean constitution, indirect restorations. We can choose between conventional and resin cements. Pre-treatment prior of tooth structure. Regardless of the type of the resin cement, we have two types. Tooth cement interface that happen between the cement and internal surface of the restoration, and we have cement restoration interface. For those bonds to form, the tooth and the internal surface of the restoration should be pre-treated. How we can pre-treat it of the tooth structure? Resin cements mainly adhere to the tooth structure through micromechanical retention. To achieve this micromechanical retention, the usual adhesive steps of etching, priming, and bonding should be performed on the enamel and dentin to form a stable hybrid layer. Some cements use etch-rinse adhesive systems, and some cements use self-etch resin cements. Newer cements use it names self-adhesive cements. Care should be taken that the bonding substrates are clean and free from fluid contamination. Pre-treatment of the internal surface of restoration. A good adhesion to internal surface of restoration requires two things. Roughening of the internal surface of restorations to increase surface area for bonding, and second, increasing the wettability of the cement to the restoration and forming chemical bonds between ceramic and the fillers and the cement, okay? Depending on the restoration materials, the first procedure is done through air abrasion, sandblasting, or etching with hydrofluoric acid for ceramic and composite restoration, or application of an alloy primer for restorations with metal substrates. The second procedure is achieved by applying silane. Okay, the silane makes the ceramic chemically adhere to the resin cement through covalent and hydrogen bonds. Then we'll know more about the classification of dental ceramics, so we can know which resin cements we can use, or if I want to choose conventional cement too. Dental ceramics can be divided into two groups: the silica-based ceramics and non-silica-based ceramics. Silica that contains low to moderate strength ceramics, and non-silica, it's more stronger and it has high strength properties like zirconium and etc. The silica-based ceramics classified into feldspathic porcelains, Louisite reinforced ceramics, lithium disilicate ceramics. This template can help us to divide this silica-based ceramics and that one for non-silica-based ceramics. Care should be taken not to cover etch when we know more than about preparing, because when we are preparing by the internal surface of the restoration by hydrofluoric acid, it can be weakened the bond between the ceramic and resin cement. After hydrofluoric acid, a white residue sometimes forms on the surface of the porcelain. This white residue is potential contaminant and should be removed prior to silane application. Okay? hydrofluoric acids, roof and the internal surface of the restoration, and it's available by concentration between 2.5 to 10% of etching time, between 2 to 3 minutes. One important thing to remember that hydrofluoric acid etchant for the ceramic is very prone to contamination with oil fluids. And avoid overetch the porcelain with hydrofluoric acid. Like I told you before, it can weaken the bond between the ceramic and resin cement. Silane coupling agents, or simply silane, ensure a good bond between the hydroxyl groups of the ceramic and the organic portion of the resin cements. The silane is applied on the internal ceramic surface and then air dried. The silanated surface is then air dry with warm air. Hydrofluoric acid is very prone to contamination with oil fluids. Okay, for indirect restorations, include sandblasting followed by phosphoric acid etching. For internal surface of restoration, the sandblasting roughness the internal surface, while phosphoric acid etching cleans the sandblasting surface of the bris. Other authors طبعا recommended sandblasting followed by application of silane. Physical and mechanical properties of resin cement. Resin cements are approximately 20 stronger and 130 stronger toughener in flexure than conventional cements, which make them the material of choice of cementation in all ceramic restorations. First of property for resin cement is compressive strength. Luting cement should have good compressive strength to be able to withstand masticating forces in the mouth. Second, flexure strength. The cement should have adequate flexure strength to be able to transmit the stresses between the tooth surface and restoration without breaking. Film thickness and viscosity. A low cement film thickness improves seating of the restoration and decreases marginal discrepancies. Solubility and water absorption. Resin cements are insoluble in oil fluids. Being resins, they absorb water, and when rinsed cements absorb water, their flexure strength is decreased. So we have to do good isolation. Factors related to resin cement, I put it in this template. You can take, okay. For now, we'll talk about bond strength. Adequate bond strength to the underlying tooth structure is very important. Different types of resin cements will exhibit different type of bond strength to enamel and dentin. The choice of resin cement greatly depends on degree of retention needed. The more retention is needed, like shorter crowns, preparation with too much taper, higher bond strength is better, okay? We can see for between retentive preparation and non-retentive preparation. Non-retentive, we use conventional, we use resin cements. We need brine, bond, and resin cements. For retentive preparation, we can use conventional or resin cements. Non-retentive preparation, shorter crown, also we need to use resin cements. And also for inlays, onlays, and veneers, we have to use dual cure or light cure cement, okay, for veneers. Now, depth of a cure and degree of polymerization. Self-curing resin cements, it's depend on chemical reaction and between, chemical reaction between metal restorations, porcelain fused to metal, and thick ceramic restorations. The peroxide molecules are the ones that's responsible for color shifting agent after. I don't like to use it, especially if I have places that I can't do control of contamination and I can't do isolation. So I use it for this kinds of cementations. Dual cured resin cements. These cements cured by both light curing and chemical curing. Okay. The initial set is usually achieved with the light curing is quickly see the gingival margins. The self-curing component ensures the cement will cure underneath restorations that are too thick or too opaque to allow transmission of light through it. We can see the light distribution that and different types of light cures. It's very important to check your light cures at your dental office to check its ability to curing your restorations. Light cure resin cements, as most, if not all, resin cements have a lot of curing components. The depth of cure, the degree of polymerization is a very important factor to consider. Okay, insufficient polymerization of resin cements can lead to increase in solubility, especially at the margins, leading to marginal gaps and secondary caries, marginal discoloration, pulpal reaction, increased fluid absorption, and changes in color too. Insufficient polymerization resin cement has decreased the hardness, fracture toughness, wear resistance, and can also lead to lower bond strength. Now let's see the classification of resin cements. Generally, the etch and rinse cements yield the highest bond strength to enamel, while self-etch resin cements show higher bond strength to dentin. Okay, so etch and rinse, it's better, the highest and the strongest for enamel. Self-etch rinse, it's higher bond strength to dentin. Resin cements, two kinds: conventional resin cements and self-resin cements. We can see this short video that explains how the overview of the entire cementing procedure for silicate ceramic. Firstly, the surface of restoration is etched using hydrofluoric acid. The surface of the tooth structure is etched by phosphoric acid. Both acids are rinsed after a few seconds. Saline is then applied to the ceramic and prime bond applied to the tooth structure. The solvent of the adhesive is air dried. The adhesive layer must be light cured right after application if wall thickness and ceramic exceed 2.5 mm. We can see the surfaces of the tooth and ceramic are now coated with the resin cement of the restoration and placed of the position. The cement is then light cured for 20 seconds from each direction, buccal lingual occlusion, if required. The adhesive is cured as much as possible through the restorations, but at least along the marginal. Placement of all metal PFM and all sorts of high-strength ceramic restorations provided insufficient retentions. We can use conventional cementations. We can see the differences between the universal, ceram, and Calibra veneers. In summary, the key to successful cementations and preventing post-operative sensitivity with etch and rinse cements. First, don't over-dry the tooth, especially after etching. Limit etching time to 15 seconds only on the dentin. Ensure adequate sealing of the dentatubules through proper application of the dental bonding agent. Ensure proper tooth isolation. And when using self or dual-cured resin cements, use a self-cure activator to prevent incompatibilities between the amine initiator and the acidic. We can see that for the universal, there is no additional bonding agent is necessary. Okay, we can see that if we have silicate ceramic, we have to use resin cements. It has higher aesthetics. By the conventional cements, it has high flexure property. And the indications for conventional is for crowns, bridges, and inlays, onlays, especially those with deep cavities and few walls remaining. Important notes to memorize: don't over-dry the tooth, and also don't keep the phosphoric acid more than 15 seconds on the dentin. Ensure proper tooth isolation. Okay, And now for dual cure cement should be light cured to gain initial immediate set to protect the cement on the margin and ensures adequate marginal seal. We can see a simplified guide to resin cement section. We can see the differences between total etch, self-etching, self-adhesive properties, and the points that we are focusing on, it's related to retention, isolation, aesthetic demand, materials strength, bonding substrate. Okay, clinical procedures. I think it's the most interesting section of the lecture for today. Okay, sorry. A flowable composite should never be used to cement thick tooth-colored inlays and onlays as light will not penetrate through the thick materials, resulting to inadequate polymerization. This may cause pulpal death from the unreacted monomers. Please notice and memorize this point. Okay, now we see this video. The tooth was cleaned with a slurry of pumice to remove surface debris that may interfere with bonding, and gently dry the surface and apply a thin layer of bonding and then light curing. An amount of resin cement, I like to apply it in a deep point just to make sure that it's the internal walls are well coated with cement to minimize voids, and a small amount of resin also for the interproximal area and proximal margins. And then I apply the onlays. I use this micro brush to clean in a gel phase. Don't wait to the finish time of the setting time. Only the first minute you can clean gently and press light pressure on the onlays just to make sure that it's adequate and fitting the surface. The internal surface of the illustration was also coated with resin cements. I like this micro brush to clean the margin of the illustration. The external surface of the onlay was coated with a thin layer of petroleum gel or Vaseline you can use at clinic to facilitate subsequent cleanup. Care was taken not to place this jelly on the adhesive surface, okay? And self-etch adhesive is used to immediate dentin sealing. Self-primer applied using light rubbing for 20 seconds. And slow steady pressure will give enough time for excess cement to flow out, aiding in the proper sealing of the illustration. A glossy surface after self-etching priming, that means the primer has been treated in 2 dentate tubules. Okay, proximal finishing. Preparation for inlays, onlays involve a lot of dentin. So usually it's more than 2 millimeter in thickness. So we have to use dual cure for cementing over or onlays. This sectional matrix that I use to clean the over-luting cements. And this is the final result after cementation. Chemical initiation of gel phase. Even without the application of light Calibra Ceram and Calibra Universal will start to gel phase after 1 to 2 minutes in the mouth. Remain in a gelled state for about 1 minute. In this phase, you can remove the excess cements gently. Flowable composite, as I told you before, should never use under a thick tooth-colored inlays because it will cause pulpal death from underneath monomers. And then we can see the cement was cured for 1 to 2 seconds, and by track curing or track wave technique. And the cement is not cured completely until the excess cement is removed. You have to remove all the excess cement by matrix, metal matrix, blade, dental floss, however you feel that you are comfort. You have to make sure that the tray of fittings of the inlay and notice a slight gap, if you have gaps or not. If you forgot between a surface of the restoration and the tooth, there's some space, you can fill it with a micro brush of and cemented. This is the metal matrix that I use. And now we can see this case of the 4 anteriors. We can see how the color and shade of the veneers, it's almost the same of the shade of the adjacent teeth. And I just recommend to you that when you are doing the cementation, use a sticky stick. And this technique that I use contains a sticky wax to help me to seat the veneers on the tooth. And I use Teflon tape, dental white tape. Okay. I use light curing for cementing the veneers. The try-in is very important phase. And this is the last result of that case. Now for this, for another case, we can see if I have a cementation for sublingual veneers, I usually use adrenaline cord and do cementation under isolation. And contamination from gingival bleeding or from this circular fluid, it's very important. Take cure and remove excess cement with periodontal curate or scaler. And don't forget to use retraction cord and remove it after finishing the restoration. That's cementing. And that is the final restoration of this case. We can see that there's no difference between veneers and the crown's color. Why I told you before that the try-in is very important, because I know the exactly shade that I use for crowns and the shade for the reason cement shade that I use for veneers to make matching colors between them. This is the step-by-step how we can do the tooth surface pre-treated for cementation, acid etch enamel and dentin for 15 seconds, and then for dentin also it will be not more than 15 seconds. Rinse for 20 seconds, apply thin layer of adhesive, and then light curing. Apply thin layer of adhesive for entire surface of the veneers. Dry it with I like to apply it like zigzag, okay, layers. And also I use micro brush. Opaque cements are used to plug the darkness of severely colored, discolored teeth, but it gives a natural appearance, and I don't like to use it at my dental office. I usually prefer neutral color or translucent shade. This is the zigzag way how I put cementation of the internal surface of the restorations to avoid the darkest spots or to avoid voids on while doing cementations. The choice of resin cement will depend mainly on the degree of retention required. So color shift becomes not much of a factor with thicker veneers. Dual cured resin cements might even be more preferable than lighter cured if we have thicker veneers than traditional ones. Important points to remember. For ceramic crowns, use dual cured resin cements, and the crown should be cemented using light gradual pressure. When loading the cements, margins should be well coated with cements. An oxygen prior, I use it, and I prefer to use it on the margin. This is try-in. See the difference between the 2-1 and 1-2, different colors. I choose different shades of resin cements. One is darker and one is brighter. So it's very important to know exactly the cement shade that you use. Generally, we use the cement shade, the same shade of the veneers, okay? This is oxygen barrier on margins to protect sitting cements from oxygen, and it's used to protect the cement on the margin while the self-curing polymerization is taking place. And we can see by this videos how isolation is done. It's easy to do it in anterior teeth. It's more complex in the posteriorly, and we can see how gently applying air on bonding to keep a thin layer of bond. Okay. Shade shifts. It's very important to understand why it's happening. Okay. And another case that is before and this is after, we can see how it's gonna be for finally. Color shifts, we know that resins that contain tetraethylamine benzyl peroxide and self-cured and dual cured, and that is tend to darken with time. Okay, that's why we use light curing cement for veneers, not dual cure. We can see how we are cleaning up the resin cements gently in a gel phase, 1 to 2 seconds by light curing, and then we are doing the cleaning. Some dentists like to cement tooth by tooth. Some dentists prefer to put two together or all together. It depends. Okay. And that is for the final result of this case. Always try to use the same shade of the adjacent teeth if you have 1 unit or 2 units of restorations. 75% of dentists, sorry, I don't know what's going on. 75% of dentists that have had to remove cement with burr, and it's wrong. By Explore or by hand instrument, it's easy cleanup of the cement and is best achieved through called gel phase. Okay, when we have excess cement is tack cured for the buccal and lingual, move the light and make sure its total curing time of 10 seconds and is not exceed proximally. Don't depend on one surface and cure it. This is very important articles if you want to read more about the color shifting and influencing of factors of the final shade of the metal-free ceramics restorations, and that one talking about the effect of resin cement brand on the color of the zirconia paste restorations. And also this article is very useful for effect of cement color and tooth shaded background on the final color of lithium disilicate and zirconia reinforced. And this is the bears that I use for the finishing after cementation. I usually call the patients after 48 hours or 1 week to do final finishing and make the final appearance of the margins and interproximally and occlusion. This is what I use at my dental office, and I like this one so much for the interproximal areas, and that for bonding. And thank you. If you have any questions, I hope to add it.
Thank you, Dr. for the amazing presentation. It's full of information, of course, I can say, and I can see some questions here. So one of the questions, there are a couple of them in the chat, so I'll start with them before I do that. So is it possible to cement veneers without using rubber dam?
Yes, it's if you can do isolation for the anterior, you can use cementing without rubber dam.
Another one just related to this.
And
about
and my answer related to the to book that I prepared from Guide to Resin Cements. It's not my talk. It's not my practice experience. You can do cementation without rubber dam if you can do good isolation.
Good. So how about removing excess cement under gingival sulcus? How to remove them if I'm not using rubber dam?
I told you that you can use scaler or gingival scalper.
Great. So here is another question. Is do you do immediate dentin sealing?
Immediate.
Dentin sealing. I'm not sure about this.
I don't know what they mean about this question.
Yeah. Okay. So let's go with the other one. So what may you explain what's the sandblasting? Does it have the same effect of etching for roughening the surface?
Sandblasting usually laboratories send our restoration, and he did sandblasting before sending, you know. So hydrofluoric acid or sandblasting, it's equal the same of properties to improve adhesion to the resin cement.
Great. You cement veneers with resin cement in veneers?
Yes, I usually no. I use it. I use a try-in just to know the shade that I want to use finally. Sometimes I have